the setup where you are doing.
Okay.
But usually platelet-rich plasma people do, and that is good enough.
Okay, that's the most common
that is
method.
most common method, and that gives good result, and that is with a reasonable rate also. Is cost effective.
Makes sense. That's why it's so
It is common.
popular among the
popular
patients.
among.
You explained to me how surgery works. Sometimes the factors are exterior, sometimes the factors are interior. As I told you, I have people who are older in my house. They have friends. Whenever they go to an orthopedic surgeon, the first thing they suggest, instead of assessing the situation, if it's a minor condition, major condition, it always results in surgery. Old people comparatively are a little scared of surgery because it's irreversible, and age factor also come into the picture. So they are a little skeptical about that. So do you feel like surgery is suggested always, or it's just the corporate hospitals pushing this?
No, exactly speaking, most of the doctor, they give the options for non-interventional procedures.
Oh.
Like physiotherapy, like exercise,
Okay.
weight, weight and see, and if really that is in the grade 3, grade 4, then surgeons, they suggest for surgery.
Okay.
Because grade 3 and grade 4, this osteoarthritis, the knee issues, they are graded. Grade 1, grade 2, grade 3. Grade 1 is initial period, grade 4 is the last stage. In the grade 4, what happens, there is no menisci, what I was telling, no, there is no menisci at all. That is very thin, and one bone is just kissing to other bone. That time you cannot do much about you cannot rely on the regenerative procedures. You have to go for a knee replacement. That is the best idea. And second thing, nowadays the knee surgeries are done in most of the centers, and people have the expertise. So knee surgeries are nowadays safe.
Okay.
So there is no reason to be scared about the surgeries. If at all somebody is giving the options and they are recommending the surgery, then there are some points to be noted. That is the reason they are giving the options. Okay. And most of the way you are talking about the pushing in the corporate hospital, to some extent it is correct, but most of the surgeons, they are not like without going for conservative, they directly go for surgery. I have not seen in my 32 years of practice.
Okay. As a layman without any medical experience, this is what I've noticed. So I'm not sure why that happens. The only reason I asked you that question is because post the surgery, they still have the pain. So why that is? Because surgery was the option suggested to them. If they still have the pain, there should be a reason medically and scientifically, which we are not aware of.
Of course, there are scientific reasons. So why the few patients, they have pain after surgery because of the musculoskeletal reason. If the pain in the knee is primarily because of your musculoskeletal cause, then post surgery also patient will get pain, or the 20 to 30% of the pain will reduce because of the intra-articular elements, but other part will be remaining there.
Okay.
And other thing is, most of the patients they go for surgery. After surgery, the rehabilitation part they neglect. Because surgical part, it is expensive, and they squeeze themselves to do the surgery. Financially they squeezed themselves. Then there is no fund left for your rehabilitation program. Then they neglect it. That's why most of the patients, they keep on complaining the pain.
Okay, so when you say rehabilitation, do you mean physiotherapy and interventional pain management?
Not interventional pain, mostly the physiotherapy.
Okay.
If after physiotherapy, a patient is not getting pain relief, then they should they come to the pain physician, and we evaluate what exactly the cause of the pain, why the pain is not getting relief with the regular medicines and physiotherapy.
Okay.
Then accordingly we give the treatment. We do nerve ablation, and we give the treatment in the muscles.
Okay.
Those things we do. There are 3-4 muscles which is innervating. This particular innervating means the which are supplying to the joint.
Okay.
We go and target those nerves which are from this side here, one is here, and 3-4 areas.
Okay.
And we go and precision needle prick we do.
Okay.
And we do the radio frequency ablation of those particular nerves. First we give local anesthesia, then give the diagnostic block. Afterwards we give the radio frequency ablation, so that this patient will not get pain.
I just have one more question for you. This is something that older crowd would want me to ask. It's about arthritis. So I don't know the difference between osteoarthritis and arthritis, but I'm guessing the pain would still be almost the same. So mostly when they get arthritis, they're like, now we have to take medicines only and live the rest of our lives in pain, etc. But I believe that after knowing you for a while and after seeing the patients how much relief they've got, I want to know how you are treating patients with arthritis that are living comparatively pain-free life, because some patients are struggling so much that they can't get up from their bed to go to the washroom. How are you helping these patients so they can live a normal life while having arthritis?
See, there are two types of arthritis. One is, means in broadly, there are two types of arthritis. One is osteoarthritis, which is mostly the old age. This is age related. Other is rheumatoid arthritis, that is the autoimmune disease itself. This is not only the knee joint is involved, almost all the joints of the body is involved. That is rheumatoid arthritis. That is another subject altogether, that is to be treated by a rheumatologist. If that is not properly managed, or patient doesn't go to rheumatologist properly, then that joints erodes, and the erosion occurs, then they have to go for knee surgery.
Okay.
If the way you told, the patient is not in a condition where you don't expect the patient to go out or something like that. You expect that patient is bedridden, and they have to he or she has to go to the bed, to the washroom only. Then that type of patients, there's no point in going for surgery.
Okay.
Because those type of patients are very risky for surgery. Then we intervene. What exactly we do? We go and ablate those nerves, so that patient will not have pain. Though there is osteoarthritis is still persisting, but patient will not have pain. But those are like moribund patients, like patients who are paralyzed.
Okay.
Or patients who are having end stage of cancer.
Okay.
And they are a few months or years to go. Those type of patients having a lot of pain in the knee because of arthritis. Now, like a patient was having lot of pain and arthritis, now is detected as a cancer. Now the lifespan is very limited. That time we can give relief with this type of nerve ablations.
Okay, so the condition still exists, but you can relieve them of
Relieve
pain
the
a
pain,
little bit.
yes.
Okay.
That is our main aim.
Okay.
That is called as palliative pain management.
That's called
Palliative pain management.
Okay.
For the cancer patients.
Cancer patients. So even though you're not a rheumatologist, can you relieve the pain for a rheumatoid arthritis patient?
Yeah, rheumatoid arthritis, the medicinal part is managed by the rheumatologist. But the intervention part, like SI joint, that's knee joint, all those joints, when they are having lot of pain and they are not going for surgery, or that knee joint is not in a stage to go for surgery, that is in the grade 1, grade 2, then we intervene and we give treatment, so that patient gets relief and will continue his normal life without surgery.
Nice. It's a great thing that you're doing, because at that stage in life, having so much problems and pain at the same time, it doesn't make any sense to put them through that. Well, that's all the questions that I had for you today. I've learned a lot. Thank you so much for taking the time out today.
Thank you. Thank you.